you know. The talk will be available after. So it's a great pleasure to introduce Dr. Reena Khanna, who you have seen is associate professor at the Western University. She is a worldwide known clinical researcher. Actually, she completed the internal medicine residency at Western University, gastroenterology fellowship at McMaster's, and then she went on with the advanced fellowship for IBD at the Cleveland Clinic. For those who don't know that, that's one of the best clinics worldwide to actually learn clinical IBD as well as being exposed to the surgical aspects of IBD. And then she became a clinical trialist and completed MSc in epidemiology at McMaster's. And basically, then she went home, and now she's working at the Western University, once again as associate professor, clinical researcher, clinical trialist. And without any further ado, once again, it's a great pleasure to have a talk by Reena tonight for us, evolving treatment targets in IBD. And with that, I mute myself and the floor is yours, Reena. Thank you.
So thank you so much, Peter, for that warm introduction. Thank you, everybody, for this invitation and for attending tonight. It is my absolute pleasure to give this talk. I think I think it's this is a topic. So I am an IBD physician, but I also do research half of the time, and so this is a topic that's near and dear to my heart and something I think about all the time on my research side and on my clinical trials side. So today, I'm not really going to talk so much about research methodologies, but more so why we're seeing endpoints in IBD evolve. And for those of you in the space, why we're seeing physicians and patients discussing different endpoints. And I'll try to use my crystal ball a little and talk about where I think the future might go to. And so I'm happy to start my talk, and then I'm really hoping to leave some time at the end because the part I'm most excited about is engaging with you and having some discussion. So I'm really going to talk a little bit about these evolving endpoints and treatment targets in IBD, and I'll talk a little bit about the clinical trials, but also I'll talk more so about what we're doing in clinical practice because I think that is the piece that's probably most relevant to most of us on this line. So these are my disclosures, and this is roughly the format we're going to follow. I know it looks like a lot, but as you can tell, I'm a fast talker, and I think we'll get through most of this with a lot of time to spare. So we'll talk a little bit about this treat to target, and I think we do need to understand some the basics of IBD before we can kind of talk about where we are today. So what we do understand is that Crohn's and ulcerative colitis are these inflammatory conditions. There's inflammation, we think, in the GI tract. That inflammation can lead to, over time, what happens is that inflammation doesn't just sit there. Our bodies are constantly repairing that inflammation, and then it's forming again, and then healing and forming, and that cycle of damage and repair can lead to layers of scar tissue that form. And over years and years and years of that scar tissue forming and healing, patients can get narrowings in the bowel. We call that a stricture. Later, they can get fistulas or abscesses. Later, they might need surgery. And then the process starts over and over and over. And so over the course of time with IBD, we do worry about these complications. And we also worry about repeated episodes of surgery that might be required. Now, we've been so lucky in the last many years to have several new therapies hit our clinics. And we've been so excited about having options to actually offer our patients. And I think what we realized is that initially, despite the fact that we had new therapies available, we were still seeing that these complications emerging. And so there are two major reasons why we think patients continue to follow this trajectory. One is we think treatments are sometimes not started early enough. And two, we do worry that we may not be targeting the right treatment endpoints in our clinic. And so if we're not targeting the right endpoints, we might not actually be healing the bowel, and we may not break this cycle very readily. And so Initially, I think there was some concern that maybe we can't break this cycle. So even with our medications, that we might not be breaking this cycle. And so this is data from a trial. You don't need to focus a lot on the actual trial data. This was actually one of the first trials I ran. It's called the REACT study. It looked at treating patients conventionally. So that's they start with steroids and then they gradually move up to mild immunosuppression and then to a more to the biologics versus the other way around, where we treated people earlier with the most effective agents. And basically, what this shows, if we treat people early on with effective therapies, we can reduce the rates of surgery, serious complications, hospitalization, and all of these outcomes put together by 2 years. So, just not a new drug, not doing anything fancy, just treating people with more effective therapies early on can actually break that cycle. And so I think this is one of the most important messages we got from this study was that we do have the ability to change the course and we do have the ability to prevent bad outcomes in our patients. Now, this is really what medicine is about. We often say that we give people blood pressure medications to prevent a stroke or aspirin to prevent a heart attack. And these data kind of tell us that in IBD, we might be able to give therapies early on to prevent outcomes down the road. And so I think that's a really exciting message. And I think that's something that gives a lot of hope to me as a provider, but also to patients that we may actually be able to intervene. Now, this is really exciting data. But what we noticed is if you actually look at these two treatment arms, so treating people aggressively up front versus that conventional management, if you looked at symptoms across that same 2-year period, there was really no difference between these two arms. And so you don't have to worry a lot about the numbers on it. Essentially, what this data shows is that there was no difference in symptoms. So this doesn't really add up. So patients didn't feel any different. And yet we were able to impact major adverse outcomes. And so a second really important message we got from this data is that especially in Crohn's disease, symptoms don't always tell us what's actually happening at the tissue level. And so symptoms don't always line up with what's actually happening with our with our medications. And it really set the tone that we need to be adding something objective to just symptom management. So we also need to be looking for something beyond symptoms to target our therapies. And so and then we started emerging more data on what those additional things we should be looking for when we start patients on therapy. I always tell patients when I start a drug, there's no point in being on a medication if it's not actually helping. Every medication, even if it's Tylenol, will have potential side effects. And so there's no point in being exposed to any potential side effects if you're not reaping the benefits. And so how do we decide if patients are benefiting? And how do we decide if a therapy is worth any potential risks? There was more and more data emerging that looking at the actual tissue, so looking at the bowel to heal. We've all heard of people having ulcers when we scope them with Crohn's and colitis. And so looking at whether those ulcers actually heal, something much more objective, actually is more predictive of what happens to patients down the road. So if you look at this particular graph, patients who actually healed those ulcers were much less likely to have surgery 1 year later compared to patients who still had ulcers after being treated. And so we've learned that symptoms don't predict what happens down the road, but healing the bowel does seem to predict what happens down the road. And that's why you may have heard in clinics or when you're hearing people talk, this real focus on looking at what actually happens to the tissue beyond symptoms alone. And so really what's come into play in the inflammatory bowel space is this treat to target pathway where people are suggesting that when a patient has active disease, we pick a therapy, whichever therapy is most appropriate with once you've discussed with the patient, and then you keep reassessing people over and over, and you keep tweaking your therapy until you hit your target. And your target should be symptoms, but also something objective. Now, this actually targets those two areas that I mentioned to you. By reassessing patients repeatedly, we're going to escalate therapies and get them on effective therapies earlier on. And the second thing is we're actually looking for something more objective in order to base our treatment decisions so that we can hopefully prevent some of those major adverse outcomes down the road. So this is why Treat to Target really evolved, was to correct some of the what people were perceiving as possible flaws in previous treatment paradigms. So this is where the field has landed. Now, more specifically, and we're going to come back to this slide a lot. I know it's a very busy slide, but we talk about this treat to target, but what is the actual target? So what should we actually be looking for? Should we be looking at what happens at a scope? When we look at the scope with colonoscopy, and there's no more ulcers, is that the target? Should we be looking at biopsies with no inflammation? Is that the target? Is it MRI scanning? Is it a CRP? Is it a fecal calprotectin? And so this approach is really helpful, but it doesn't actually tell us what we should be looking for in our clinics. And so there are these guidelines that have recently been published, which are supposed to tell us exactly what those targets should be. And so this is the Crohn's disease algorithm. And in a second, I'll show you the ulcerative colitis version. And basically what these guidelines say is our target changes with time. So initially, when a patient is flaring and feeling very unwell, our very first target, our immediate targets, are to get that patient feeling better. So if someone's having 20 bowel movements a day, full with blood, they can't possibly function in the way they want to in terms of going to work or being a parent or going to school. And so we need to get that patient feeling better right away. That patient wants to feel better right away. So in that very immediate phase, we want to target symptoms because that's what's most important to our patients. And therefore, it's very important to us. Now, in the intermediate phase, we want to go beyond just feeling better, and we want this person to be in complete remission, ideally. And we want to start looking at those objective markers. Remember, I told you symptoms alone are not enough to predict what will happen in the future or to determine whether our treatment's successful. And so we start wanting to look for that CRP, which is a marker of inflammation in the blood, or the fecal calprotectin, which is a marker of inflammation in the stool, to start normalizing. And then beyond that, as a longer term goal, we actually want to have this mucosal healing. So we actually want the tissue, the colon, to actually heal, and so all those ulcers to have gone away. And more so, we ideally want to normalize quality of life and prevent disability in our patients. So this is the overall targets that we should be looking for. And so this aligns with what's important to our patients, I think. Immediately, they want to feel better, but in the long term, they want to heal their bowel and hopefully prevent surgeries and improve their quality of life. And similarly, in ulcerative colitis, there's very similar targets. The actual scores and the actual symptoms or numbers that we use are slightly different, but the principles are identical. Initially, we want people to feel better. Then in intermediate, we want them to be in remission with normalization of that blood and stool inflammation. And in the long term, we want to heal all those ulcers in their bowel. And so these are now our guidelines for use in clinical practice. And so for those of you who attend clinic or who are involved in IBD management, you'll certainly see a lot of these objective markers as being forefront in those discussions. And the reason for it is we know that targeting these more objective markers, some of these things can be cumbersome to do blood work, to do stool tests, to do scopes, but we know in the long term that will hopefully prevent adverse outcomes in our patients and will hopefully lead to better outcomes in the IBD space overall. And so from those STRIDE guidelines, this is their treat to target algorithm that we keep reassessing patients over and over. I think in older days, in decades bygone, people used to be put on therapy and they would stay on that therapy for years and years and years without being reassessed. And that was what was acceptable at the time. I think now our paradigms have changed, that we want to be a little bit more proactive and not keep people on therapies if they're not effective. And that's why we check more frequently to ensure that we want to check more frequently to ensure that patients are hitting all of these targets. So let's talk in more detail about some of the targets in the IBD space. Now, one thing I will say is in the old days, clinic, in my opinion, really helped shape our clinical trials. So our clinical trial, we would often say as patients and physicians that being on steroids does not constitute being in remission. And so we saw the clinical trials incorporate that definition that steroid-free remission was really important. And then what we're starting to see is the trials are now shaping our clinics. So we're seeing endpoints in trials that are much more rigorous than what I've shown you. So they are talking about looking at transmural healing, which means MRI healing, so the entire thickness of the bowel wall, or looking at biopsy specimen and making sure there's no inflammation at the tissue level. And so this is likely where our targets will be in the future in clinic, but the clinical trials are helping us to determine what exact thresholds we want to use for these targets. And I think those trials will eventually start influencing our clinical practice. So exciting times ahead. I think these paradigms are going to change ahead, but where are we today? And I'm quickly going to go through Crohn's and then we'll talk a bit about UC. Now, I showed you this slide already that these are the potential targets. So what targets do we have? Symptoms, CRP, inflammation in the blood, fecal calprotectin, which is inflammation in the stool, and endoscopy. And so what does this mean in the Crohn's disease space? Don't worry about the details of this. The CDAI is one of the clinical indices that we use. Now, typically it's been used more in trials than it has been used in clinical practice. What is the problem with symptoms in inflammatory bowel disease? Symptoms are really, really, really important. And they're really important because it influences how a patient feels every day. And it's really important because it's something that that impacts our patient's functioning. However, if we were only to make treatment decisions based on symptoms, it has many, many problems. And so one problem is, and I think most of you would probably recognize this, is patients without IBD often score higher on our clinical indices than patients with IBD. And so for clinical medicine, any score that where another disease scores higher than the disease you're trying to measure is a little bit problematic. And so I think even for people without IBD, if you've ever had food poisoning or people with IBS or people with celiac disease can actually score very highly on many of our inflammatory bowel disease indices. And that's problematic because patients can often have coexisting diagnoses. They can have a Crohn's, but they can also have IBS. And it's hard sometimes for us to tell the difference. So if we only made treatment decisions based on symptoms, we would be over or under treating a proportion of patients. And so that's why we don't discount that a patient's having symptoms. We just need to confirm that the symptoms are actually from the IBD and not due to an alternate cause, because we wouldn't change the immunosuppression in that case. We would treat the alternate cause. And so this is also a slide that is a little bit busy, and I apologize. Essentially, what it is trying to show is if you look at symptoms along the bottom and you look at endoscopy, so basically what we're seeing with a colonoscope, if the two were related to each other, we'd see a nice linear line. But here it looks like a snowstorm because the two don't match up with what's happening with each other at all. And the reason for that is exactly what I've told you, because there's so many other reasons why patients can experience symptoms. And so symptoms are important. We have to address symptoms. We have to make sure we're treating symptoms for our patient's benefit, but we can't only make treatment decisions in IBD based on symptoms if we want to make sure we're doing the best possible job for our patients. The other problem with a lot of these indices is they exclude a lot of the patients we see in clinic. And so what these are supposed to show you are patients with surgery, patients with fistulas, and patients with ostomy have never truly, these indices were not designed to assess any of these patient subgroups. And so we use them, but they weren't formally designed for these patient populations, which again is problematic. A lot of the regulatory bodies like the FDA or the EMA, which is the FDA equivalent in Europe, has really focused on using what we call PROs or patient-reported outcomes. And this is the CDAI, just to see it written out. And many of these features are actually not patient reported. And so we don't truly have a validated patient reported outcome in the inflammatory bowel disease space. There are 3 items within the CDAI that are patient reported, and the rest are usually laboratory or other parameters that don't constitute a patient reported outcome. So you may see this term PRO, and PRO basically just means we're using these patient reported items from the CDAI, and these are the items that actually fall into the STRIDE guidelines. Now, so symptoms aren't going to give us the whole answer. So where do biomarkers fit in? So where can we use something like a CRP? So CRP is that inflammatory test in the blood, or fecal calprotectin, the inflammatory test in the stool. These can be very helpful. We can use them for treating, to assess disease activity. We can use them to assess efficacy. We can use them in that treat to target paradigm, and it helps us risk stratify our patients. Let's look at CRP first. CRP is that inflammatory marker in the blood. It is really, although it is helpful, it is not specific to inflammatory bowel disease. So if a patient had pneumonia, if they fractured their ankle, if they have any other physiologic stress, we will see this marker go up. So although it is helpful, it is not specific to inflammatory bowel disease. And we don't need to worry about the exact cytokines, but we know there's many different immune pathways that can lead to IBD. And you need to have specific pathways in order to produce a CRP. And they estimate about 20% of patients, so that's 1 in 5, it's a very high number of patients with IBD don't use the pathway that produces CRP. So no matter how bad their disease is, they may never mount a CRP response. And so not having a CRP doesn't 100% include or exclude the diagnosis of inflammatory bowel disease. So although it's helpful, it's not really very sensitive, and it's not very specific to the diagnosis we're trying to assess. And so people have really moved towards this fecal calprotectin. So it's a poop test which can measure inflammation in the poop. Now, this has the advantage of being much more specific to the gut. Again, it is not entirely specific to inflammatory bowel disease. If someone had an infection in the gut, for example, it would also go up, but shouldn't be influenced so much by like pneumonia or a broken ankle or any of these other parameters. And we believe more patients will actually demonstrate an elevation in fecal calprotectin, particularly if they have disease in the colon. One of the limitations of a fecal calprotectin is it may not affect higher inflammation in the gut, like people who have Crohn's in the stomach or esophagus, as much as the colon. Now, this has become a really important biomarker. And again, this is a study. We don't need to look at all the details. Essentially, in this study, they took patients with Crohn's disease who were really very early in their treatment course. And so essentially, they were given a course of prednisone and then randomized to either conventional management, which means that their treatment was escalated based on symptoms and prednisone use, or if they would escalate therapies also based on fecal calprotectin and CRP. And what this basically shows is by using fecal calprotectin and CRP, at the end of 48 weeks, more patients were likely to actually have mucosal healing. So rather than only using symptoms, if we use something objective, we're able to meet more stringent endpoints for our patients down the road. So this is a reoccurring theme. Now, this is a very busy slide, so I apologize for this. And so don't worry, I'll give you the punchline. The punchline is, unlike symptoms, which they say the correlation between symptoms and what we see in terms of the bowel is less than flipping a coin, less than 50%, whereas how specific fecal calprotectin is about 90%. So 90% sensitive and specific, so much more of an objective marker. It's a much more objective marker for making treatment decisions. Having said that, a fecal calprotectin, even though it's 90% sensitive and specific, means that still there's that 10% wiggle room. And so very often when people are making small changes to therapy, increasing the dose, they often rely on a fecal calprotectin, sometimes for very critical decisions in patient care where where a patient may not have a lot of treatment options. Very often people will want something that doesn't leave that 10% margin of error, and we'll look for something even more sensitive and specific than a fecal calprotectin. So really important test, but every test has certain limitations. And so this is that same slide for fecal calprotectin in UC, and we see similar data. So where does endoscopy fit into Crohn's disease? Now, typically, this has been considered the gold standard, meaning that we want to see that the bowel actually heals. And so for those of you who are not familiar, this first slide is a very inflamed colon, and this is what a normal colon looks like. And that would be ideal, what we would see pre and post therapy. Now, what we do know is that endoscopy can be used for what we call prognostication. So endoscopy can help us predict what's going to happen to a patient down the road. And so patients who have deep ulcers on their initial endoscopy are more likely to develop a complication called a fistula, which is a connection between the bowel and something it shouldn't be connected to, or are more likely to require surgery down the road. And so we know what the bowel actually looks like is predictive of what may actually happen to the patient down the road. So having more severe disease leads to potentially more complications and more serious outcomes. We also know the opposite is true. If we can heal those ulcers early on. So this is one study that looked at a particular drug and patients who were able to heal the bowel by 12 weeks were much more likely to still be in remission 1 year later. So healing that bowel early on predicted a good outcome later on. So we've seen severe disease predicts worse outcomes later on, and healing the bowel predicts good outcomes later on. And this is why for a very long time, the field has really depended on looking at the bowel and determining if those ulcers have actually healed. There's lots of other data sets, and we don't need to belabor this, but the deeper the remission, the deeper. So this study looked at whether patients had whether they had no remission, which is the lighter blue, whether they had clinical remission, so only their symptoms were under control, or whether they had symptoms and endoscopy under control. And patients who had that deepest remission were less likely to have relapses, hospitalization, were less likely to have surgery. And so overall, the deeper the remission, the better the overall outcomes. Now, one of the areas we're starting to hear people talk about, and we talked a little bit about this when we talked about the STRIDE guidelines, is this transmural. So we know Crohn's disease affects all the layers of the bowel wall, and people have talked a lot about whether we should be looking for healing of the entire bowel wall. And so we do know there's lots of data out there, accumulating data, different indices. It does seem to be a really good technique. It does depend a little bit on making sure that the people are well trained for reading these MRIs. And I think the biggest issue we have in Canada is just access to an MRI. And so we've seen now a lot of people using bowel ultrasound, which may be something that's very common in Europe, and it's still sort of taking its feet more so in Canada. So we may see transmural healing as being in the future. As of now, I think just the exact definitions and what level of healing leads to improvement down the road is still something that is being worked out. And so in terms of histology are the biopsies that we take in Crohn's disease. We do think this is important, healing the bowel. There's just a lot of questions that still remain. And so this may be in the future of treatment, but I think there's still a ways that we need to go before we're able to completely define how to use this in our clinical practices. So the summary for Crohn's disease is, where are we today? And so what the regulatory bodies are asking us is really to use this PRO or CDAI, which I showed you earlier on. And that's what they're using for clinical trials. And for endoscopy, there's a specific scale called an SESCD. In clinical practice, what our guidelines have suggested is we focus on stool frequency and abdominal pain. For endoscopy, we can look for healing of those ulcers. We can also use biomarkers such as fecal calprotectin and CRP. And histology and imaging, I think, are part of the future, but I don't think they're quite prime time for routine use in our daily clinical practices quite yet. Now, I'm going to very quickly go through the ulcerative colitis part because it's very similar to what we've seen in Crohn's. And so this is the slide that I showed you. We have, again, symptoms, CRP and fecal calprotectin, and endoscopy as potential options for use. And the one thing that we do see on the end of this one is histology. And I do think histology is much more closer to becoming prime time in ulcerative colitis than it is in Crohn's disease. So these are the options we have. We can look at symptoms, we can look through a scope, or we can actually look at the tissue. And so in terms of endoscopy, so symptoms symptoms are similar to Crohn's disease, not perfect, but do correlate a little bit better with disease activity. And the symptom that seems to be the most sensitive and specific for picking up active ulcerative colitis is rectal bleeding. So when people see blood in the stool, that seems to be the most sensitive and specific. Now, in terms of endoscopy, there are several different endoscopic scales that that can be used. The most common is this modified Mayo endoscopic score, which we see here. And so this is very commonly used in clinical practice and has been fairly well studied over time. Now, why is endoscopy so important? So this Mayo score that I showed you is a 4-point scale going from 0 to 3, where 0 is virtually normal and 3 is very severe disease with ulcerations. And so what we see is the lower a patient's score, so the closer they are to having that normal bowel, the more likely they are to maintain remission over time. And then there's lots of data that shows that the lower this endoscopy score, closer to normal, the less likely this patient will go on to have colectomy at a later time. Now, what about histology? Why is histology taking such an important role in many of the clinical trials? And we're hearing a lot about it in potentially for use in clinical practice. What this slide shows is that even patients who have pretty much normal endoscopy, so they have this score of 0 or different scores that people use, there is a large percentage of patients that can still have disease when we look at their biopsies. So some data suggest up to 40% can still have inflammation at that tissue level. And why is that inflammation at the tissue level so important? There's lots of data that have emerged, and I'm just showing you one slide here, which suggests that healing the bowel at the histologic, so at the tissue level, at the cellular level, reduces the risk of adverse outcomes down the road, such as hospitalization and colectomy. Now, why is this not exactly prime time yet? I think there are several different endoscopic indices, and I think we're certainly trying to, one of the areas of active research right now is to determine which index is most predictive of what happens to patients and how deep does that remission actually need to be? How many biopsies do we need to take? Where do we take those biopsies exactly? And so there are some questions around how to operationalize this to do our patients the best service we can do. But I do think this is getting pretty close to becoming prime time. Stride 2 just came out. There was a Stride 1. Stride 2 added to Stride 1, and I think Stride 3 will likely have histology as an outcome going forward. And so here's the summary for ulcerative colitis. The regulatory bodies, FDA, EMA, Health Canada, really still rely on that Mayo endoscopic score. Our clinical guidelines suggest using stool frequency and rectal bleeding. For endoscopy, we tend to use this Mayo score, and histology and imaging are not quite prime time yet, but I do think histology is getting pretty close in the ulcerative colitis space. And so we did talk about this a lot today. I won't belabor the point for you, but these clinical guidelines, these STRIDE guidelines have really helped shape how we're managing patients. And so when you're in clinic, when you're here, when you're discussing with other patients, when you're discussing with providers, you'll hopefully hear them talking a lot more of adding some of these objective markers. And although they are cumbersome, we do know that overall they have been associated with good outcomes down the road, more so than just treating symptoms alone, because we don't want to be under or over treating patients to the best of our ability. Now, there are also guidelines. I'm an adult GI, but there are also guidelines for in the pediatric space to help us understand how to treat these patients. They're very similar. They just use pediatric indices as opposed to our adult indices. Again, I showed you the ulcerative colitis data, and there is the flip, a pediatric ulcerative colitis data. Now, I showed you this earlier as well. This is why this treat to target has become so important, because we know we can actually attain better outcomes for our patients if we really aim to get those objective markers under control. And so one of the things that we still need some definitions around this transmural healing and histologic healing. But I think all of us who practice clinical medicine also recognize there's still a need for more therapies, because there are unfortunately still, we've come a very long way, but there are still limited therapies. And if we are going to be targeting these harder endpoints, we need more therapies in order to get more patients to that optimal outcome. And so that is what I spend a lot of my time doing, is designing studies, and hopefully there will be several new therapies on the horizon. Now, the one thing I will point out is I showed you in that original treat to target these 12-week intervals where we're seeing patients being assessed. They do say that immediate, intermediate, long-term goals, it should really be tailored towards each individual agent. Now, admittedly, this is mainly based on expert opinion from the STRIDE guidelines, but we're getting even more specific as to how soon we want to see treatment response. And if not, we would want to move on to another therapy. Now, I didn't talk about this today. I wasn't sure if it would be an interest, but one of the areas I work a lot on is endpoints in clinical trials. And I can say the endpoints in our current clinical trials are becoming more and more and more rigorous. And I think some of that rigor in those trials is helping us to make sure that the drugs coming to market will hopefully be efficacious and hopefully be hopefully safe. Some of that safety data will also accumulate with time, but I think some of those endpoints that they're pushing towards, we're seeing this histologic healing, and we're seeing them push the bar further and further with each therapy, will also help define whether those harder endpoints are going to be useful in our clinical practice. So the two are really very intertwined and really very helpful. And so those are the formal slides that I'd put together for you guys today. But I think now it's the fun part where I will really look forward to being able to chat with you and to hear some of your questions. So thank you for joining.
So thank you very much, Reena. That was really a fascinating talk, more about, how we target our therapies. And, we have a lots of questions about, the new therapies. So I will just, maybe pose one or two. But before that, just to summarize, for me, it was fascinating to see, and this is the take-home message, at least to me, that, it's not just important which therapy we use, but how we use it and how we assess it. So that was, I guess, the essence of this talk, to convince you that we have to be objective. Otherwise, we fool ourselves, and we think that we do something, sometimes the right thing, and it might not be the case. So some questions about therapies. Mainly, we had some therapies so far. And if you want to chat, put something in the chat, please go ahead. So until then, I would like to ask, there was a very specific question about, do biologics always work? And what do you think about the change of the biologics to the biosimilars? Did this, flip the coin? Is this adding another layer? What's your point on, the biologic question and the biosimilar question, Reena?
For sure. Yeah, I wish I could say biologics always work. Unfortunately, they don't. And I think this is why we still need more therapies. I think we do know that there Crohn's and colitis, psoriasis and rheumatoid arthritis kind of fall in the same family of diseases, and yet therapies that sometimes work in those other two diseases don't work in IBD, unfortunately. It is a little bit trickier to treat, and this is why we have fewer biologics available to us than they do in other spaces. So I think one of the things that makes it very hard is there's several immune pathways that can actually lead to IBD, and we aren't quite so sophisticated yet in our science to be able to measure blood or measure tissue and know which drug works for which patient perfectly, right? And so that is actually an area of interest that I have in terms of my own personal research, trying to do that personalized medicine. We do see it in other spaces like oncology, where they actually target therapies, and we're not quite there yet. Typically in IBD, we've been a little bit stuck in terms of getting those response rates between 30 and 50%, but we do have some new agents coming down the pipeline where we're seeing much higher efficacy rates. And so there's still a lot of hope, and there's a lot of research and development in the field. And so as of today, I think we really need from a scientific community to have more specific ways to target drugs to patients. But I think from a clinical community, we are still anticipating and really hopeful that we'll have more drugs so that we can help more patients. In terms of the biosimilars, I think there was a lot of debate about this back and forth, and a lot of I think we've learned from our colleagues in the West. We've learned from our colleagues in Europe that these biosimilars seem to perform as well as the originators in terms of safety and efficacy. And if they can lead to cost savings in many jurisdictions, then hopefully some of that can get channeled back into the system and into treating more patients. That would be ideal. And I think that's something we all need to be lobbying for, to make sure that that money savings gets used wisely.
So thank you very much, Reena. There was multiple questions and also in the chat about whether we have a cure in the near future and which, or just please highlight one or two of the new biologicals that would come upon the 4 or 5 that we use in the clinic daily in the practice. So which do you think are the most promising one according to your interpretation so far?
Yeah, for sure. In terms of a cure, I wish, and that's kind of like my mission. So I hope one day. But I think right now we're still learning a lot. So we've certainly come a very, very, very long way in IBD, and even in my short career, I know I can say that the field is really turning, and there's so much research and so much excitement. My hope is at some point. I don't know what you would define as long-term versus short-term. I don't anticipate a cure in the next few years, unfortunately. But I do think we have more and more effective therapies that are available. Canada has a very high incidence rates of Crohn's and colitis, as we all know. And we're still learning so much about it, about the different immune pathways. We don't even fully understand why people sometimes even get it, right? We say it's a mixture of your genes and the environment and possibly some sort of bacteria. And so I think we still have a lot to learn, which will help us eventually get to the cure. In terms of new agents down the pipeline, I think overall the field is really excited about 2 classes, the IL-23 class. And so there's several IL-23s coming. These are agents that are highly effective in psoriasis and in certain rheumatologic conditions. So psoriasis, I think I mentioned to you, is it's in the same family as Crohn's.
So I don't cut you, Reena, just for the ones who use it. This is Stellara, the one that we use as of now in the clinic, and then the new agents, coming are a little bit improved or different, but basically the same pathway. So
Yeah, instead of exactly, it's Stellara's 12 and 23. These are 23 specific. And in psoriasis, so we can't always extrapolate because I told you it doesn't always work the same in psoriasis. But the dermatologists claim these IL-23 specific are the best agents they've ever had for psoriasis. And so we hope if we can capitalize on even a bit of that efficacy, it could be a game changer in the IBD space. And then the other one are these JAK1 selective, so similar to tofacitinib, but theoretically targeting fewer pathways and theoretically should be safer, although that remains to be determined. And the reason there's so much excitement around that is in the ulcerative colitis data, this is the molecule that I mentioned, where we're seeing efficacy rates that have broken all of our previous ceilings. So if it has a good safety profile, it again could be a game changer. So there's two molecules that we're expecting to be released in the fall this year, one for UC and one for Crohn's. And then in the spring, we should see the opposite, they'll flip. And so we're really excited to welcome two potentially very exciting molecules to our treatment armamentarium.
Thank you, Reena. And I will try to merge, a complex question of, the text and then what I have seen on the papers and sent in. That is about, if symptoms are not good, and this was about the talk. And, you suggested the use of sometimes endoscopy, sometimes the biomarkers. And we know also that some of the symptoms might be more functional, like, the functional bowel disease like IBS. So how much of these symptoms you think are mainly on the IBS side? And how often would you suggest yourself routinely to assess, I know it's a very general question because there are different players, like different patients, mild or severe, to actually check these markers if the patient is, I guess, in control or active.
So so you're right. This is a very very challenging question. It's but I think overall, I think so ultimately we always want to do what's best for that patient sitting in front of us, right? That's our job, that's our mission in life, is to try to do the best possible service for that person who is trusting us and relying on us. And so I think ultimately, if someone has symptoms, I want to make sure that I am offering them the best possible therapy. So if their IBD is active, I want to get it under control to prevent complications down the road. And I actually say this to patients: part of my job is to think of you today. The other part of my job is to think of you when you're 100 years old. And I want to make sure your bowel is healthy and intact when you're 100 years, the best that I possibly can. And so if that means adding to your immunosuppression, then that's the thing to do. On the other hand, if it is not, if it's related to IBS or something that doesn't respond to immunosuppression, then adding immunosuppression is actually doing a disservice, because we are adding more medications and the patient's unlikely to benefit because IBS has a different mechanism. So pretty much most patients, I'd say virtually every patient that is having new symptoms, I will do some sort of screening to ensure that this is actually inflammatory before I am adding anti-inflammatory therapies to their regimen, or anti-immunosuppression to their regimen. So whether that's something as simple as a CRP or something as a fecal cal, it depends a lot on that patient and how recently I have done some investigations for them. And it also, in truth, sometimes during COVID depended on what we had access to. So there's a bit of a mix, but I think for the most part, it's not to discount symptoms. And I want to be clear. I know I was a bit hard on symptoms in my talk, but I think symptoms are important to our patients and affect their quality of life. So we want to address the symptoms. We just want to address them in a logical way, because if it's not their Crohn's, then it's our job to try to figure out what it could be so that we can still help, right? So it's not that we don't want to look at symptoms. We just need to know what's causing the symptoms, and it may not always be Crohn's.
Thank you. Last question, and I let you go. You did a very nice job in answering all of our concerns and interest. And that was a question in the chat, actually. What do you think about, the follow-up therapy? So if you start with some advanced therapy, biologicals, and because of multiple reasons, the patient could fail and needs to go on the second and the third and the fourth. Do you think they could be still the same efficacy, or what's the hope there, or we have to expect lesser efficacy? What would you suggest on these, to the patients?
Yeah, so I think this is one of the other burning fire questions in the IBD space is how to, what we call sequence. That's the formal way of which order we put these biologics in. So is there an actual order? Like, should we be always starting with one and then and I mentioned this many times today, but there's many immune pathways that can lead to IBD, and each therapy we give will target certain pathways, right? And so the concept is sometimes people do very well for a long time and then they fail their therapy, and there's lots of reasons for that. They might clear it, they might form antibodies, but one concept is you might shift to another pathway because you block these ones. So your immune system is smart and shifts to a different pathway to start triggering the disease again. So in an ideal world, back to this precision medicine, we would actually measure which pathway is active and then treat with the drug that would target that. We just aren't fully there yet, not even close to there yet. In truth, it's an area that we are working on. There's a lot of research in this space, but we're still working on it. What we do know from a lot of data is usually the first drug that we give has the best shot to work. And you'll often see that we try to make an evidence-based decision and we try to maximize that therapy because it usually has the greatest treatment. Now, whether it is a fact that the first treatment is actually the most effective, or if it means people who fail drugs typically have more severe disease, we're not entirely sure. So I think the data suggests the first drug would be the most effective. However, I think from a very clinical experience, we all know that just because the first one doesn't work, doesn't mean the second, third, or fourth won't. And so I think all of us have experience of many patients who failed many drugs, were on their last possible option, kind of holding our breath, and their ulcers disappear. So I wouldn't lose hope if the first drug hasn't quite worked. I think we've all had patients that can still benefit from subsequent therapies.
That's a very positive ending. So I thank you very much, Reena, for all the fabulous talk and the great discussion. And it was a great evening. I don't want to keep anyone longer up. Thank you very much for being there for us. And we really enjoyed. Thank you in the name of all the group and all the specialists from the McGill group, and also hopefully our patient side. So with that, I close today's session. I stop recording officially.